Siamo. Hello, everyone. It's truly a pleasure to introduce a free top-level webinar on our channel. I am Ciro Bocchetti, working behind the scenes since 2014. I'm one of the partners of this company, and I manage this project from a digital and administrative point of view. So I have seen it growing like a child in the last 8 years, more or less. Today, we will spend on Zerodonto 1 hour together with two friends of us, an old friend called Arnaldo Castellucci and a new friend called Grazia Baraghini. Grazia is the founder of Your Dental Coach, and probably most of you already know Arnaldo. The subject of the webinar is useful to all dentists who do a little bit of everything, and obviously to endodontists in particular. We are ready, and we are just waiting a couple of minutes to let people join the various channels. We are live on many channels. In fact, it is possible to attend this event on our Facebook page, our Instagram profile, YouTube, Facebook group. The main one, Zerodonto Dentistry, with more than 300,000 members, and the Italian one, Zerodonto Italia Odontoiatria. I remember we organized the last live streaming a couple of years ago. We planned some online events during the first lockdown due to the COVID, and our fan base really appreciated them. Fortunately, I was talking about this with Arnaldo some minutes ago. All around the world, in-person events are possible again, even better in the next future. During this webinar, you will see some news about a 4-day challenge that Arnaldo and Grazia have organized for the next week. 4 days of endodontics called the Endodontics Breakthrough Challenge. The ticket is ridiculously cheap, and we suggest those interested to jump in. Now, I don't want to take up any more time. The presentation will be more interesting than me, and I am going to disappear and will keep staying here in the backstage as I usually do. Bye.
Thank you, Ciro.
So now can I start my presentation?
Yes, you can. Go ahead.
Okay. Okay, so hi everybody and welcome to my webinar. It's a pleasure for me to be here with you. I know that there are people from different parts of the world interested in listening my lecture, my presentation. Before I start, of course, I want to say thanks to Ciro, to Grazia, and to Fabio Cozzolino to organize and to advertise this webinar. The topic I'm going to cover, which will probably, I tell you already now, will be maybe a few minutes more than 1 hour, because I put together a lot of material, but I'll try to stay on time. The topic of today is the most common mistakes in endodontic therapy and how to avoid them. As you probably know, I live on referrals. I only see patients, 99% of my patients are referred by colleagues. And of course, the patients that are referred to me are almost always a difficult case, a retreatment, and broken instrument, perforations, people who are not able to find the canal, and all kinds of mistakes that you can imagine. So this is why I have a lot of experience, because this is the only thing I do every single day when I come to the office. And since the day I started, which was many years ago. Okay, so let's see now where I say we because I can also make some mistake. So diagnosis, treatment plan, access cavity, finding canal orifices, shaping the canal, and finally during the obturation procedure. Okay, let's start from the very beginning and the typical mistake that can be made making a wrong diagnosis, the typical example is this one here, where you see that the lesion is involving the apex of the lateral incisor and just a little bit the central incisor. You may think that the lateral incisor is necrotic. The lateral incisor is perfectly vital. So the root canal treatment must be done only to the tooth involved and responsible of the lesion, which is the central incisor. How do I know that this lateral incisor is vital? Just making a vitality test. Very, very simple and very easy. Look at this other case. Again, you see a lateral, an endo lesion involving two teeth, but the central incisor is necrotic and the lateral incisor is vital. So we don't need absolutely to touch the pulp tissue of the lateral incisor. Why I'm showing cases like this? Because many, many times these people, these patients are referred not to an endodontist, but to an oral surgeon. And because the colleague maybe is afraid of the big lesion, and so he thinks that the only therapy is surgery, and so he sends the patient to the oral surgeon. The oral surgeon, in cases like this, asks specifically to do the root canal treatment also to the central incisor, because during the surgical procedure, he has to scratch and remove all the granulation tissue. And doing this, he's going to section the blood supply of the central incisor. And this is the reason why he asked for the root canal treatment before the surgery. This is a big mistake because first of all, we don't need to scratch and remove the granulation tissue up to the very last cell. And second, the tooth, the central, is vital. Don't touch it, okay? Look at this other case. In this case, you see a lesion in the bifurcation of the molar. Well, the molar is vital. And this is not a perio lesion because, as you can see, the level of the bone is pretty good. The patient is a young patient with perfect condition of oral hygiene. I don't see any reason from a periodontal point of view why we should have a lesion in the bifurcation of the molar. However, the molar is vital. When I show this case, somebody say, maybe there's a crack. No, impossible to have a crack and the lesion in a vital tooth. Some other says the occlusal trauma is not an occlusal trauma. Well, it's obvious when you take a look of the X-ray that the tooth responsible of the lesion is the premolar, and the premolar has a big lesion which is draining through the periodontal ligament of the bifurcation of the molar. So this is an endo lesion, not perio. It's an endo lesion caused by the adjacent to the premolar. So what do we do in this case? Of course, right now, if I take a periodontal probe, I can probe the defect from one side to the other. But the only thing to do is to take care of the necrotic pulp tissue and remove it from the 3 canals, not just 2 or 1, of the adjacent premolar. As you see, these are the teeth, the canal, the lingual, mesiobuccal, and distobuccal. The 3 canals under the microscope are very easy to identify and to treat. And so in this case, I always do when I have a sinus tract, because as I said already, this is just a sinus tract draining through the bifurcation of the molar and originating from the adjacent to the premolar. So in cases like this, like any similar case, when I have a sinus tract, I clean and shape the canal, let's say today, and then I put a sterile cotton pellet in the pulp chamber and temporary seal to seal the access cavity of the premolar. And then I wait 1 week for the probing and for the sinus tract to disappear. So 1 week later, this young patient came back to me. The defect was not probable anymore, so the sinus tract was closed. And so that was the time for the 3-dimensional obturation of the root canal system. And this is after 5 months, and this is after 5 years, without doing anything to the molar, of course. This is a similar lesion. I would say identical lesion, because again, this is not a perio lesion. The tooth is necrotic, obviously, and this is the lesion in the bifurcation, because the lesion is draining through the periodontal ligament inside the bifurcation, but has nothing to do with the perio problems. And so again, in a case like this, clean a shape in one visit, the 3 canals, and then in 1 week, we want to make sure that the sinus tract is closed. The defect is not probable anymore, and so we can obturate. And this is the 2-year recall evaluation with the perfect healing. Look at this. This looks exactly like a granuloma in the palatal root of this upper molar. But the problem is that the molar is vital. So this is not a lesion of endodontic origin. This is not a granuloma because the tooth is vital. But this is a perio problem. This is the infrabony pocket around the apex of the palatal root. As you see, look at the periodontal defect. So this is a case that I received many years ago from a periodontist friend of mine whose name is Gianno Ricci. You probably know him. And these were the happy times when in cases like this, only the involved root was extracted. Today, we know very well that cases like this, many times, the entire tooth is extracted and replaced with an implant. At that time, I did the root canal therapy. I didn't spend any time, just the orifice sealed with some material and ready for the hemisection, for amputation of the root. And then, so this is my immediate post-op. And then I sent the patient back to, oh my God, I did something wrong. What happened to my presentation? Okay, here we are. I sent the patient back to Dr. Gianno Ricci. He removed the palatal root, and this is the recall evaluation with a perfect and nice healing. Now look at this. This is another case which can be cause of big mistakes. This young patient with a perfect oral hygiene, he doesn't suffer of periodontal disease. This is nothing, okay? And this is the, oh my God, excuse me, but I want you to see. Okay. Okay, so this is the same patient. One day, he comes with this problem at the gingiva and the sulcus of the upper left cuspid. And look at the periodontal probe. It's disappearing, but the tooth is vital. And the patient is young, the oral hygiene is excellent, and he doesn't suffer at all of periodontal disease. Well, look what happens in 1 week. 1 week later, there's a problem with the 1 week later. So, excuse me. Okay. 1 week later, this is the defect, disappeared. What happened? What did I do so magic in this case? I didn't do anything to the cuspid. No perio, no endo, no nothing. What I did was the endodontic therapy to the lateral incisor, which was necrotic and was draining through the periodontal ligament of the cuspid. So very easy in cases like this to make mistakes. And now look at these 2 lesions. They are identical. One is this around the second lower molar, and one is this one around the third molar. The 2 lesions are completely different because this is a lesion of endodontic origin. This tooth is necrotic, okay? And of course, I can put a periodontal probe down to here, but I'm not probing a periodontal defect. I'm probing a sinus tract. So you may say, how do I know? Well, in a case like this, the tooth is necrotic. So the first thing to do is do a root canal therapy, cleaning and shaping today. And then in 1 week, we see the patient to see what happened to the sinus tract.
Arnaldo, sorry
Yes.
if I interrupt you, but there
Yes.
is a question. So
Yes.
a colleague is asking you if you consider the PCE1 and PCE2 scanner useful to avoid errors in the preparation of endodontic access.
Excuse me, I'm ignorant. What is the PCE1 and PCE2? I don't know.
You will, David, please.
PCE. I don't know. This is David. This is his name. May you ask him where he from? I'm
Where are
sure.
you from? Yeah.
Where is he from?
We are waiting for the answer.
Okay.
Okay.
Probably is from the United States, because the United States, they used to make abbreviation of everything.
Yeah.
The pedontal ligament is the PDL. The lesion of endodontic is the LEO. The general practitioner is GP. The chiropractor is the GP. But I live in Italy, and I like to know the entire world.
Okay, we can go ahead, and then we will discuss about
Okay.
that later on.
Yes. Okay. So I said this is necrotic. So what I do in a case like this, I clean a shape today, and then I want to see in 1 week if the defect is not probable anymore. And it was not probable. In this case, the situation is completely different. This tooth is vital, is a third molar. As you see, there is calculus everywhere. So this is a lesion of periodontic origin. So they look exactly the same, but this is perio and this is endo. So don't make confusion. And this is the post-op of the endo lesion many, many years ago. So I know exactly the root canal anatomy has been probably over-instrumented. I have some extrusion of garapercha, everything you want. However, the lesion is completely disappeared. Look at this. I'm doing the endo in this lower second molar. I take an x-ray with my instrument, and then I said, oh my goodness, did I make a perforation? How comes that the instrument looks exactly in the middle of the bifurcation? Relax, it's no perforation, but this is a C-shaped canal, and I'm introducing the instrument in this canal over here, which on the radiograph seems to be in the bifurcation. So I'm very happy that about 5 years ago, maybe late, I know, but I decided to install in my office the CBCT machine, which is absolutely very useful. And again, like the microscope, I couldn't live without the microscope. I couldn't practice without the microscope. I do everything under the microscope. And today I couldn't practice anymore without the CBCT, because it gives me so many right information that are impossible to get from a B-dimensional film. And you have no idea how many times, and I will show you later a few cases, thanks to the CBCT, I decided to change my treatment plan, because I saw that the thing was different from what I expected. So this is the C-shaped canal after the obturation. So how to avoid mistakes? Well, first of all, to have a good knowledge of the root canal anatomy. So we know that the upper molar, they have the palatal MB1 and B2, but also DB1 and DB2 sometimes. And then in the lower molar, we can have 2 distal and 1, 2, and 3 in the mesial. And then we can have in upper molar MB1, MB2, and MB3. And if they are all of them independent, of course, we have failures. And these are examples of root canal anatomy with upper molar and lower molars treated the way they should be treated. So good knowledge of root canal anatomy, and be familiar with vitality test. The vitality test is absolutely important, so that if you see that the lesion is, the root is surrounded by granulation tissue, but it tests vital, that means that pulp tissue has nothing to do with the lesion. The lesion depends from another tooth, the adjacent tooth, and if someone needs to do surgery, please don't touch the blood vessel of the vital tooth. Okay, so let me speak very quickly about the vitality test, that not many endodontists, and for sure not many periodontists, are familiar with the vitality test. I'll show you cases referred to me for the root canal treatment, and then the tooth was vital, and I sent the tooth back to them. So the cold test, for instance, we take the empty plastic of the needle for the injection of anesthesia, and I use them to make 3 centimeters of ice. So I have like a pencil of ice, and with ice, I touch the cervical area where the enamel is thinner. You know, the enamel is not a good conductor of heat. And so the thermal test, like the electric test, must be done in the cervical area. If I want to be more specific, I isolate the tooth under the rubber dam, and I fill the rubber dam and submerge that tooth with cold water. And then I have a very nice response. This is the typical case I was talking to you 1 minute ago. I received this lady from a periodontist. Of course, I will not mention his name. He sent me the patient and the X-ray with the garapercha in the sulcus, showing that according to him, I was looking at the sinus tract of the second molar. I saw the X-ray and I said, I don't think this is the sinus tract of the tooth of the second molar. Maybe it's the impacted third molar responsible of the sinus tract. So I took a piece of coal or a piece of ice, and I touched with the ice the metal of the crown of this abutment. And the patient said, ouch. And then I said, oh, you feel cold? And then she said, yes. And then I said, well, the tooth is vital. And then she said, wonderful. And then I said, no, lady, not wonderful. Terrible news, because that means that your vital tooth has nothing to do with this sinus tract that depends on the third molar. So go back to your periodontist and tell him that the tooth is vital and you don't need my endodontic therapy. And then I don't know what happened, but for sure, I'm sure I can imagine that the third molar was removed, and also the second molar has been for sure removed. So the hot test also is important to make a confirmed diagnosis of pulpitis. And this is the heat carrier that I use today for the Shields technique, with this tip, which is specifically studied to make a hot test. If you want to confirm a diagnosis of pulpitis, you have to reproduce the symptom of the patient. The symptom of the patient, typically in pulpitis, is terrible pain with hot, and then reproduce the symptom with something hot. The electric test also is very important, as well as the periodontist has the perio probe in his tray. We have the electric test very close to us when we want to test the vitality. And this is the old machine, the old instrument that I used years ago. This is the new one from is the diagnostic from Zerodonto. Very, very reliable. And the most important vitality test, however, is the last one, the cavity test. If I have any doubt with the previous test, the one that will confirm if the tooth is necrotic or vital is the cavity test. What is the cavity test? Cavity test means to make a cavity, and without anesthesia, of course. And as soon as you touch the dentin, you will feel and hear the answer of the patient, and the patient will inform you of the dentinal sensitivity if the tooth is vital, or he will not say anything if the tooth is necrotic. So every time, and I know that many people disagree with me, but I'm sorry, but I am right and they are wrong. Every time you have a suspicion, you suspect a necrotic tooth, please make your access cavity without anesthesia. Don't tell me that the patient is afraid of dentistry, of endo, and the rubber dam clamp is too tight. These are stupid excuses. You have to convince the patient for their best interest that I need to start working without anesthesia, because if that something is wrong, meaning my diagnosis was wrong and the tooth is not necrotic but is vital, I need to be informed. So what the patient is feeling is pain. For me, it's not pain, it's a very precious information. Okay, and this is a typical case that I treated many, many years ago. This is a patient that was referred to me by my good friend Gianno Ricci, was a third molar, which was an abutment of a very, very long bridge many years ago before osteo integration of implants. And let's consider that the occlusal surface was in gold when he came to me, okay? Don't look at this amalgam. So the patient had this crown, and on the lingual side, he had the sinus tract. And if you look at the X-ray shows a radiolucency all around the two roots. And this is the reason why Dr. Ricci sent the patient to me for the root canal treatment. So I started my access cavity through the gold, and the patient said, under the rubber dam, "Doctor, I feel something." And then I said, "Yes, relax. You are feeling vibrations. Give me a few minutes, and I will stop using the high-speed burr. You will not feel any vibration. You will not feel anything." So I started the second time. I went already through the gold and was starting to touch the dentin underneath there. And so the patient told me, "Doctor, I told you I feel something." And then I said, "Oh, please, don't you see the radiolucency? Don't you see the sinus tract? Your tooth for sure is necrotic. So please leave me alone and let me work." So I start for the third time, and the patient took my hands out of his mouth and he said, "Doctor, I feel pain." Then I said, "Oh my goodness, maybe the tooth is vital. The patient is absolutely right, and I was going to make a big mistake." So I stopped immediately and I put some amalgam, because at the time there was no composite, no adhesion, nothing, many, many years ago. And then I sent the patient back to Dr. Gianno Ricci, the periodontist. And I told him, "Gianno, listen, the patient needs you, not me, because this is a lesion of periodontic origin. It's not a sinus tract from a lesion of endo." So what he did a wonderful curettage. And after the curettage, as you see, the sinus tract disappeared, confirming that it was a lesion of perio lesion. So if I trust someone who insists to give anesthesia so that the patient is relaxed and we are relaxed. And then I always say, anesthesia is anesthesia. It's not a tranquilizer, okay? So I don't give anesthesia to the patient in a case like this because I want to be informed if the tooth is vital, yes or not. And the tooth is vital. Can you imagine if I was working with anesthesia, I could penetrate into the pulp, in the pulp tissue, into the pulp chamber. I could see a lot of bleeding. And then I could think, oh, how strange. Part of the tooth is still vital, not part of the tooth. The pulp tissue is completely vital. Then I do my root canal treatment, and the sinus tract, of course, it does not heal. And someone can say, well, I told you, and endodontics, it not always works. It's not predictable. No. It works, and it is always predictable when it's right correctly in the right indication. However, then Gianno sent the patient back to me again, and he said, "Please do the root canal therapy because there is a bifurcation involvement." And at that time, with the bifurcation involvement, as I already told you about the upper molar before, the periodontist used to remove one root. And so this is after the removal of one root, okay? And this is after a few years, recall, and the tooth was still stable and still in the mouth, and it's remained in the mouth for many more years. And this is another similar case where this young patient is only 18 years old. And look at the sinus tract. And this patient also went back and forth several times from Gianno Ricci's office and my office, because Ricci's thought that it was an endo lesion. And then I said, "Listen, I don't see any radiolucency, so probably it's not an endo lesion." And then he said, no, I put a gutta-percha point inside the sinus tract, and for sure the distal root of the first molar is necrotic, and the fistula, the sinus tract, comes from there. And then I said, "No, Gianno, excuse me, but the pulp get inflamed and calcified and dies in a coronal to apical direction, not the opposite. So if the tooth is vital, and according to my vitality test and the cavity test that I made, the tooth was vital, it is not possible that the pulp chamber is vital and the root and the distal canal has a necrotic pulp. So if the pulp is vital here, the entire pulp is vital here. So the tooth cannot be responsible of this sinus tract. In the meantime, I told Gianno, listen, the lady is only 18 years old. Look at the third molar. It's partially impacted. Why don't you extract the third molar? Okay, look at the third molar. The sinus tract is between the first and the second molar, but the third molar is partially impacted. And so I said, Gianno, do me a favor, remove the third molar. And after the removal of the third molar, the sinus tract disappeared, confirming that was a perio lesion coming from the sulcus of the partially impacted third molar. And this is a similar case with the sinus tract between the first and second molar in another young patient. But this time I pushed down the gutta-percha point, and the gutta-percha point goes out from where? From the sulcus of the third molar. And again, you see calculus everywhere. So also in this case, the sinus tract is not of endo origin, but is of perio origin. And again, after the removal of the third molar, the sinus tract disappeared. And again, this is another case where with the vitality test, I found out that this is not a lesion of endodontic origin. This is not the sinus tract of a swelling of endo origin, because the tooth is vital. This is a perio problem, okay? So very important to make correct diagnosis and to be familiar with the vitality test. Let's see now big mistakes in the treatment plan. And let's see how to avoid the big mistakes. In this case, the molar, let me see. Yes, the molar has a lesion which apparently is involving also the second premolar. But again, the second premolar tests vital. So it means that it has nothing to do with the lesion. This is the CBCT, and look at the big radiolucency around the mesial root of the first molar, which is also involving the floor of the maxillary sinus. I noticed from the axial view that the lesion was involving only the buccal roots and not the palatal. And so I decided to do surgery on the mesiobuccal root of the molar, okay? And was a good decision. And again, this is the typical case where the oral surgeon asks for the root canal treatment of the premolar because he has to scratch the granulation tissue. Don't scratch anything. Leave the vital tooth alone. And this is the 6-month recall evaluation telling that I was absolutely right. This is another case where the lesion, it looks like involving the adjacent tooth, but the tooth is vital again. So don't make mistakes. Don't listen to the oral surgeon. The oral surgeon, maxillofacial surgeons, they should not be offended, but this is the truth. They don't know anything about endo. So please don't send patients for periapical surgery to them because they make only big mistakes and big disasters, as I will show you later on. So in this case, I did the retreatment, but was not enough. And so I decided, because there was some tissue, some material outside was also irritating. And so I raised the flap. I did my retrograde. This is my immediate post-op. And this is the 1-year recall evaluation. And again, you see the adjacent tooth remain vital, okay? This is another problem. Look at the enlargement of the periodontal ligament all around the root. This premolar abutment of the bridge has been treated from a colleague I know who use lateral condensation. And the problem is, look, big, deep pocket, very narrow, but very deep pocket, typical of what? Typical of two things, the sinus tract, yes, also of the vertical root fracture. And here, unfortunately, there was a vertical root fracture, complete loss of bone, as you see here in the coronal view. And again, in the axial view, you don't see any cortical bone anymore. And as soon as I raise the flap, this is the fracture. Methylene blue to make the fracture more evident. Okay. And of course, in a case like this, bye-bye to the abutment, bye-bye to the tooth, bye-bye to the bridge. And you can understand how angry, how upset and furious was the young patient. Okay. What do I use today to confirm the diagnosis of a vertical root fracture? I don't raise flaps anymore, unless I'm very curious and I want to document under the gingiva, like in the previous case. But look at this case. Well, this is my recall evaluation after I did the root canal therapy to the cuspid many years ago, and maybe 2 or 3 years before this X-ray. Okay, about 10 years later, this lady came back to me with the lesion between the cuspid and the lateral. And the treatment plan of the dentist was, well, the lesion is between the two teeth. Let's start doing endo to the lateral incisor. No, the lateral incisor is vital. It has nothing to do with this lesion. The lesion depends on the cuspid. And someone may say, well, maybe because it's a lateral lesion, maybe it's a lateral canal. No way, because if there was a lateral canal, I had filled the lateral canal 10 years before, and I don't see any filling of any lateral canal. The problem is another one. Many years before, the patient had all the teeth in the posterior quadrant. Now she has the removable prosthesis, which is attached only with this attachment to the crown of the cuspid. And so the consequence of this kind of prosthesis is what? Vertical fracture. So I always document a vertical fracture many, many times, not from the outside, but from the inside. So I make I remove the crown, I make my very quick access cavity, I remove my carapacial position 10 or 15 years before, and what I saw inside on the buccal wall of the canal, this line, which is the vertical fracture, corresponding of this line in the canal, I had the deep probing on the outside that this confirmed the fracture. And then, because this was many years ago when I just installed the microscope, and just for my satisfaction and my curiosity, I wanted to document the fracture also, not only from the inside, but also from the outside. And this is the well-documented fracture. And of course, the tooth was extracted. In this other case, and again, you see how important is the CBCT, because this patient has a lesion, has a sinus tract caused by the roots, maybe just the mesial one, maybe also the distal one of this upper molar. But before taking my decision, I wanted to take a CBCT to see if there was a lesion also involving the palatal. Well, let me confess something that is not so easy to do surgery on a palatal root with the buccal access, okay? And I hate to do the palatal surgery on a palatal access. So in a case like this, if there is no lesion at the apex of the palatal root, then my decision will be do the surgery only on the buccal roots without removing the crown. The post will be much easier, fast, and less invasive. Okay, so the lesion is involving only the two buccal roots, and from the coronal view, I don't see any lesion around the palatal. And also from the axial view, what I see that always happens. Someone forgot the MB2 canal. You see one obturation here and nothing there. And so the big lesion is involved in the two roots, but not the palatal. So my decision to do surgery only on the buccal roots was correct. Okay, so this is my post-op, the distal buccal and the retroseal with white MTA in the MB1 and MB2. Well, this is a recent case, so I don't have the recall evaluation, but I know the patient, he comes once in a while for other reasons, and I know he's very well. And again, here, I don't want to remove post and crown, and I will be very much less invasive if I do surgery. And this is my treatment plan. This is my retroseal in white MTA in the 3 incisors. And this is the 8-month recall with no scar tissue at all, using a submarginal incision. Look at this. This is a big, I would say, disaster, let me use this terminology, made by an oral surgeon. I'm pretty sure, I cannot guarantee, but I'm pretty sure that the pulp tissue of this lateral incisor was vital. The only tooth responsible was the central incisor. And of course, even more vital was the cuspid, surrounded by healthy bone. Okay? So look what happens to the young patient. Amalgam in the central, in the lateral, some amalgam everywhere, and a little piece of amalgam also in the cuspid, which the oral surgeon asked before surgery, please treat also the cuspid because I have to scratch the bone and everything. But the colleague was not able to find the canal, which was pretty narrow. And so during the surgery, one piece of amalgam also here. This is the face of the patient after being treated by the oral surgeon. The oral surgeons are quite rude when they treat the patient. So she has ecchymosis and swelling, pain. She was feeling terrible for the entire week or 10 days after this kind of surgery. But then, after 1 month, the sinus tract, enormous sinus tract, was still there. And the diagnosis of the oral surgeon was, my dear lady, if the fistula is still there, it means that your teeth are fractured. So I need to do extraction of the 3 of them. So you can imagine this young lady was about 30 years old, was desperate. And I don't know how, but she was referred to me, and it was hard to convince her that I had to do another surgery. And she said, oh, no, it's been so painful. And then I said, forget about the previous experience. You will not feel any pain during the surgery. You will not feel any pain after the surgery. You will not have any swelling, any ecchymosis, nothing. It's completely another story. And so this is exactly what I did. Retroseal in the central incisor. And I remember very well, let me go back for a second. As soon as I touched this amalgam with an ultrasonic tip, the cavity was not retentive at all. And the same was for the lateral incisor. So very easily I removed the 2 amalgams. And I positioned my retroseal down to here, and then down to here, and then also in the cuspid down to here. And this is the 5-year recall. And now this is one of the many patients who loved me because I saved their teeth with no pain, no swelling, no hospital, no nothing. Oh, I forgot. The treatment was done in general anesthesia and in the hospital. So this is this kind of surgery I just showed you is what I call endodontic surgery, which is surgery made for endodontic reasons, exactly like in the molar that you see now. This is another patient treated by an oral surgeon. I don't know the name of the oral surgeon, but I know for sure he's an oral surgeon. In a few seconds, I will tell you why. So this is a retrofill made because the patient had a granuloma. So the oral surgeon decided to put a retroseal. Yeah, but a retroseal on top of a absolutely completely dirty root canal or canals, because they have MB1 and MB2, full of bacteria, and that tissue is not going to work. No wonder the patient has a sinus tract. How do I know it's an oral surgeon? Because this is the signature of the oral surgeon, the scar tissue of the semilunar incision. I don't know why, but the oral surgeons, they keep using in their surgery the semilunar incision, which is absolutely to avoid. It doesn't have one single advantage in using this kind of incision in our surgery. So the flap design, correct, is a submarginal incision or the marginal incision, but not the similar incision that the oral surgeon and maxillofacial surgeon, they insist using only them. Only they use this incision. So as you see, the sinus tract is there. I remove, without damaging the crown, just a little opening of 2 millimeters in diameter. I remove the porcelain and gold crown. I negotiate MB1, MB2, palatal and distal buccal, clean and shape today, and then let's wait 1 week until the sinus tract disappeared. So this is the picture after 1 week and the sinus tract disappeared. This is my obturation the same day, and this is a 2-way recall with a nice healing. As a contrast, this is what I call microsurgical endodontics, which is made under the microscope, start to finish, from anesthesia to the removal of the suture, and is a surgical endodontic treatment, but is an endo treatment made through a surgical flap. So this must be in the hand of the endodontist, not the oral surgeon, because I repeat, and they shouldn't be offended by it, is the truth. They don't know anything about endo, okay? I know for sure because I asked to some oral surgeon that I know, and I asked him, tell me, please, during your specialty in oral surgery, how many hours of lecture did you have about endo? And the answer was 0. So they don't know anything, okay? So this is an endodontic treatment made through a surgical flap, but is made with the knowledge of the anatomy, of the knowledge of the endodontic treatment and problem, with the instrument, with the material, with everything of the endodontist, okay? And this is exactly what I did in this case, an endodontic treatment made through a surgical flap. So now this is a very unique case that I carry with me almost everywhere I go. And so maybe some of you already saw this case, so but let me very quickly show this case. This was referred to me by a colleague who was not able to finish the case and remove the piece of gutta-percha from the resorbed defect. I saw the patient under the microscope. I saw the little piece of gutta-percha, but I was not able to remove it. But even more important, I was not able to find the orifice of the apical part of the root canal. And so I decided to fill the case up to here, to the defect, with the thermoplastic gutta-percha, and then I raised the flap. When I raise the flap and I remove the granulation tissue, because of course I remove the granulation tissue, but just to have a good visibility of the lesion, of the root surface, and good control of the bleeding. And to have better control of the bleeding, here the black stuff you see is due to the use of ferric sulfate. However, removing the granulation tissue from the bony crypt and for the resorptive defect of the root, I saw the orifice of the canal. And then I asked my dental assistant, please remove the tray of the surgery and give me everything, I say everything, for non-surgical endo. So here come hand stainless steel instrument, rotary night eye, Apis locator, irrigating solution, paper points, gutta-percha, everything, okay? So this is the initial negotiation. This is the working length confirmed through the radiograph. This is the gutta-percha before surgery with the thermoplastic gutta-percha. And then at that time, I would use a ProTaper Universal and GT rotary file. Right now, I'm working having the flap raised, and the irrigation right now is made by my dental assistant only with saline solution. As soon as we have enough space inside the root canal, after being has been prepared, and having my dental assistant very close to me with the suction tip, I will use the same protocol that I use every day when I work under the rubber dam. So sodium hypochlorite, EDTA, and so on. So I complete the shape, and then I dry the canal with paper points. Now the confit, X-ray of the confit, which is too precise, has to be shortened a little. This is the down packing. Of course, I use the sheaths technique, and this is the heat carrier that I use today from a Korean company, B&L. And let me tell you now that I'm going to show you many instrument material, many microscope and many things I have no economical interest on anything I'm going to show you. Okay, so this is the nice heat carrier that I use today. Can be used for the shieldless technique or for the single wave condensation Buchanan technique, as you wish. Very nice and easy to handle because it's cordless. This is the backfill with the gun for the from the same company for with the thermoplastic gutta-percha. And now it's time for the for the obturation of the resorptive defect with white MTA. Now it's time to remove the ferric sulfate and stimulate the bleeding. And as soon as the bony crypt is full of blood, this is the time for suturing. So this is my crazy post-operative film, but you know why it looks so crazy, because I was entering through the surgical flap. This is my suture. This is the removal of the suture after 24 hours. We don't keep the suture any longer. 24, 48 hours, nothing more. This is the nice healing without any scar already after 15 days. This is my pre-op, how we started. This is the recall evaluation after 22 years. These are other recall evaluation. And of course, no scar after 22 years. This is a more recent case, a crown, a post, and here I did exactly the same root canal therapy, including the three-dimensional obturation with the surgical approach. So this is the canal prepared with the ultrasonic tips designed by my friend from Paris, Bertrand Kayat, and manufactured by Acteon. They come in the length of 3, 6, and 9 millimeters of length, and they are particularly useful in case like this, when a long portion of the root canal is left completely empty. So now, after preparing the canal space down to the post and using a paper point to carry some sealer, the same sealer that I use every day in my non-surgical endo. So I introduce the sealer inside the root canal, and now the gun that I showed you before by BNL, I pre-curved the needle in order to be able to enter inside the canal, and I injected the thermoplastic gutta-percha inside the canal. Compaction of the gutta-percha in order to leave at least 3 millimeters of space for my retroseal with white MTA. This is the MAP system from Produit Dentaire, a Swiss manufacturer, to carry the white MTA in the retroseal, in the retrocavity. This is the retroseal just made, the suture, and the recall to check the healing of the incision after 2 weeks. Perfectly healed already, I can tell, without any scar tissue. And this is my post-op. You remember this canal was completely empty down to the post, and now it's completely filled down to the post with the vertical compaction of one gutta-percha. Speaking about treatment plan, and let me show you again, maxillofacial surgeon, okay? And this is a part of my big, huge collection of mistakes made by these people. Oral surgeons and maxillofacial surgeon. Now, Alexandra, the diagnosis is a cyst in the area of upper left, central, and lateral incisors of the diameter of about 1.5 centimeters. And for this, hospital and general anesthesia and surgery. Okay? This was November 2003 in this millennium, not in the medieval. This is the panoramic radiograph of the patient. I don't see any radiolucency. I don't pay any attention to the answers of the radiologists because sometimes they describe things that we are not interested with, and they don't describe things that we are looking for. But this time, the radiologist is absolutely right. Modest periodontal disease with no, I say no, periapical inflammation. In other words, there was no cyst or of any 1.5 centimeters of diameter. However, the lady had in a general anesthesia the surgery, and the surgery was apicectomy, okay, with no retroseal. And after 30 days, the patient went back to him, maxillofacial surgery, okay, with a new sinus tract. And look at the treatment plan. Treatment plan now is two options: non-surgical endodontic retreatment after the removal of crown and post, or extraction. Extraction means money. Okay? So when I say that these people don't know anything about endo, I am correct, because this is the proof. Now, this guy is asking an endodontist to remove the crown and the post and do a non-surgical retreatment. After that, he cut the apex with a 45 degrees angle, and so that now the foramen is enormous and it's elliptical in shape. Okay, so very difficult or impossible to have a good control non-surgically of the obturation. So this is a surgical failure, and the treatment plan must be another surgery. So this is the surgery that I made when the patient was referred to me. As you can see, the bevel 45 degrees, lateral condensation here, and also a big amount of dentinal tubules completely invaded by bacteria. This black area are bacteria inside the dentinal tubules. So are you surprised if 1 month after the surgery, this kind of surgery, the patient developed again the sinus tract? Okay, so many mistakes here. Okay, if you want to use lateral condensation, but probably here the lateral condensation was not working well. And then if you cut with the 45 degrees angle and you leave a lot of cold cones like a cold spaghetti inside the root canal, which are not sealing anything, and you don't put any retroseal, and also with such a bevel, how do you seal the dentinal tubules of the palatal aspect of the cavity? And then if you leave all these tubules full of bacteria, of course your surgery is not going to work. Okay, so let me go fast to the very end, and I will show you my retroseal. And these are my retroseal. At that time, I was using a Super EBA. This is an old case before MTA was introduced into the market. Okay, as you see now, my bevel is not 45 degrees anymore. It's almost 90 degrees to the long axis. So this is my post-op, and this is after 7 months recall. And the scar tissue you see here is thanks, and is the signature of the maxillofacial surgeon, it's not mine. Look at this. This is also speaking about wrong treatment plan and wrong diagnosis. Stefano is the name of this patient. He has a sinus tract in the palatal area of the missing upper second molar here. I repeat, in the palatal area, he has a sinus tract. And because of the sinus tract, okay, Stefano received a panoramic radiograph, another panoramic radiograph with the gut aperture point in this sinus tract, an intraoral radiograph completely distorted, a tomography, a TAC, okay, not a CBCT, a tomography, which means 90% more radiation compared to the CBCT. But the best part comes now, a biopsy for the sinus tract. And the diagnosis is hyperkeratosis and acute inflammation. I don't know if you're familiar with the advertising of George Clooney advertising an Italian coffee, an espresso, and he says, what else? And I would say the same. Hyperkeratosis and acute inflammation. What else? Of course. What did you expect? But the best part is also this one here. And again, hospital of national importance and high specialty, these people. And the treatment plan is, Mr. Stefano has a sinus tract in the palatal area of the second molar, extraction of the first molar, and fistulectomy. My goodness, he wants to make a fistulectomy. because like all oral surgeon and maxillofacial surgeon, they are afraid of what? Of the epithelium, of the sinus tract, epithelium of the cystic wall, and so they are afraid of the epithelium. They are just ignorant, okay, in the etymologic meaning of the word. They ignore, they don't know anything about endo. This is Stefano in my office. This is the gutta-percha point in the sinus tract. This is after cleaning and shaping MB1 and MB2. Recall evaluation, and a few days after my cleaning and shaping, the sinus tract is gone. Now, speaking about sinus tract, I don't know if you're familiar with the name of Angelo Sargenti. He's a Swiss man who many years ago invented this sealer called N2. N2 means the second nerve. The first nerve was made by God. He invented the second one because in this sealer, to introduce in the root canal system, he put also, oh my goodness, paraformaldehyde, okay, to mummify the nerve, bacteria, and everything. So he said, don't worry about the crazy anatomy that you are asked to treat, because I give you a wonderful sealer which made miracles because it's going to mummify everything which is inside the root canal. The problem is that when he was using this marvelous sealer in patients having a sinus tract, they never went back to him with a flare up or pain or anything. But when he introduced this sealer in the root canal of a tooth not having a sinus tract, many, many times the patient went back to him with a flare up. And so his conclusion was, you don't have a flare up because you have a sinus tract. And if you don't have one sinus tract, I will make it for you. And so he invented the fistulator to make a penetration into the gingiva, the bone, and everything into the lesion to make an artificial sinus tract. So my question is somebody invented the fistulator to make the sinus tract when it is not there, when the patient comes already with the sinus tract? Be thankful. Say thank you. You will not have any flare up or reacutization or anything. Don't make a fistulectomy, please, but be thankful to the patient who comes already with a sinus tract. Okay, now let's see another case where it can be very easy to make another mistake in a treatment plan. This young lady just had the root canal therapy made by somebody else, and now after a few months or 1 year, she had a very small lesion and pain, okay, at the apex of the mesial root of the upper left second molar. And she also had a beautiful porcelain crown. She's very happy and proud of the crown. And so, and considering also the fact that she has a big smile, big mouth, like Julia Roberts, just for you to understand which kind of big mouth, very easy to do surgery in a mouth like this. Okay, so she's asking me, doctor, please don't make an access cavity in my beautiful crown. If we do surgery very quickly, very easily, you put a retroseal and that's it. And then I say, well, I love to do surgery, let me tell you, but let me take a CBCT because I want to see better and have more information about the real anatomy. And it was a good idea to take a CBCT. This is the rendering. I don't see here the distal root of the upper first molar. In the sagittal view, again, I don't see the distal root. I only see the lesion in the mesiobuccal of the second molar. The coronal view, look, this is the first molar, the palatal, and the distobuccal, and this is the mesiobuccal root of the second molar, which is between the two roots. Wow. Let me take a look of the axial view, which is the most important. And look at the arrow. The arrow is indicating the distobuccal root of the first molar. Going more and more apically, the distobuccal root of the first molar is buccal to the mesiobuccal root of the second molar, which means that if I follow the suggestion and the request of the lady to do surgery here, I have to go across the vital pulp tissue of the distal buccal root of the first molar. So obviously this is a contraindication for the surgery. And then I treated the case non-surgically. Okay. So let's see now mistakes making the access cavity. And speaking about the access cavity, let me say something about what is very much on fashion right now. Today, the smaller is the access cavity, the better you are, which is absolutely wrong. I disagree with this new concept totally, 100%. So, should we use a traditional or a ninja access? These are cases that I found in Facebook somewhere. Now, do you want to make a ninja access? I can understand people want to save tooth structure, dentin, enamel, but do you really want to save a lot of restoration? And you make a ninja access through the restoration? This is absolutely stupid. This is crazy. This is how to make your life more complicated for no reason. Look how thin are your preparation. Are you sure that enough irrigants can arrive here and enough compaction of the garapercha can arrive here? I would like to see this case not after 1 year, but after 10 years to make sure that the healing is still there. Look, very risky to enter with such an access because you are removing too much from the inside of the curvature. Where, remember, on the external surface of the root, there is a concavity in a buccal to lingual direction. So you don't have so much thickness of dentin as you may think from the x-ray, okay? Remember, always have a straight line access to the apical 1/3. Absolutely. Because if you don't have a straight line access, and I'm not afraid to show my mistake that I made many years ago, okay? Look, I made a strip perforation because look at my garapercha point, was going too much to the distal. I was working in a situation like this, like you can work when you make a ninja access, okay? So you remove, and I removed here too much tooth structure from the internal wall. And that's why I had the strip perforation. Well, I was lucky that at the recoil evaluation, the lesion almost completely disappeared. But this is not the way to do a treatment, okay? In the coronal portion of especially the mesiobuccal canal, we have a coronal curvature. And if we don't have a straight line access, this is the consequence. So a good rule not to forget when we work especially in the mesiobuccal canal of the lower molar, a mesiobuccal root of the upper molar, the reference point of the rubber stop of the instrument, hand instrument or rotary, must be the same cusp related to the canal where I'm working, not the distal lingual, like I'm working now if I start working like this. Okay, straight line access. Look at this. This is another case that I found in the Facebook somewhere. And the colleagues say the root is very thin. And if you develop he says 6% taper. Well, first of all, the taper is not measured in percentage. It's measured in hundreds of millimeters. So it's the taper is an 0.06 hundredth of millimeters of taper. However, this is not the question of the taper that we develop. Look at this garapercha point. The garapercha point goes to the distal and to the lingual for sure, which means that the colleague doesn't have a straight line access. So it's not a question of a taper. It's a question of not having a straight line access. And this is a textbook with big names inside here. And inside the several chapters, you'll find ninja also in a case like this with the why you want to save this piece of enamellar dentin. There is no reason. And this is another case, or maybe it's the same I showed before. Don't make your ninja through the restoration. This is absolutely ridiculous. This is another case. the ninja access made through the restoration. This is absolutely ridiculous because you are not saving dentin, you are just saving porcelain. Okay. In my old edition, I'm happy now that I have a new edition. In my old edition of my textbook, I have something similar, a precursor of the ninja access. Look at this case. Two composite, one in the mesial, one in the distal. I remove the composite. And of course, I remove also the bridge of enamel and dentin. But this is not to advocate the so-called ninja access, but this is to say, don't do that. This is in a section of the wrong access cavities in my textbook. And this is my post-operative film. And I'm happy to show you this article written by Elio Berutti and the entire School of Turin in the Journal of Endodontics in the 2018. And he was the winner of the 2019 Journal of Endodontics Award, like the best article written in the entire year, okay? And is an article of influence of the contracted endodontic access on root canal geometry. And the conclusion is that the traditional endodontic cavity may lead to a better preservation of the original canal anatomy during shaping compared to the contracted endodontic cavity, particularly in the apical level, because they cause transportation, okay? So in the ninja, you see transportation. In the regular, the enlargement, especially in the apical, is perfectly in the center of the original anatomy. This is a case I treated some time ago. In a case like this, where the canal are full of calcification, the pulp chamber is full of calcification, there is also a crack, okay? Do you want to make a ninja? Are you sure that with the ninja access, you are able to remove all the calcific material and to see and to diagnose the presence of the crack, okay? If you want to be conservative, fine. Don't make it too large and clean the pulp horns with ultrasonic tips. But please don't make a ninja, okay? And now we have something new, the dynamic guided endodontic access procedure. This is a nice article written by Steve Buchanan.
Arnaldo, sorry, but we cannot have time to read the article because we are a little bit...
No. Relax. I'm not reading the article. I'm just showing the title of the article. Okay?
Yeah.
Relax. I'm just showing the article, showing how complicated it is to use this technique. And remember that this machine, it costs 25 or 30 US dollars. Do you want to invest so much money to invest to negotiate a calcified root canal? Like in this case, in the article by Steve Buchanan, I have a similar case, and this is another one where I was very happy to save 25 or 30,000 US dollars. Okay. And this is a recent article published in the JOE April, 1 month ago. Limitation and management of static guide endodontic failure. The technique has limitation and iatrogenesis may occur. Possible cause of failure. What happened in this case? In case that it happened that the machine went in the wrong direction and it made a perforation instead of going in the original canal. So they finished the case. These are images from the articles. They had to do surgery. And now let me show you another mistake. It's funny. They opened the case to do a retroseal and they put a bone graft. I want to send a letter, an email to the author of the article and ask, excuse me, this is a lesion of endodontic origin. Like many lesions we treat every single day, non-surgically, and they heal perfectly without any surgery and without any bone graft. Why did you put some bone graft here? Okay, so this is my opinion about the ninja access. It's just ridiculous, okay? Please don't do it, okay? So let's see now common errors in the preparation of the access cavity. Errors related to inadequate access, like here, the access was made through the decay. Absolutely wrong. Look how many debris you leave if you go from the side. Too small. Of course, the tooth is going to change the color. And just making a regular access cavity, the tooth already improved the color. Look at this. Unfortunately, I cannot say the name of the professor at the university years ago who sent me this case because he opened the tooth for drainage, but the sinus tract was not healing. What is this radiopaque material inside here? Look at this. He misunderstood the pulp horns, and he thought they were the orifice of the canal. So one elliptical orifice for the distal and two round for the mesial. If you open the tooth like this, of course, the sinus tract is not going to heal. This is after my treatment, and this is a 2-year recall without any fistulectomy, of course. And this is another case, okay? 1, 2, 3, and 4. They were the pulp horns misinterpreted like they were canal orifice. Let's see now errors related to over-aggressive preparation. And this is typical in the lingual aspect of the lower molar. Why it happens something like this? Let me explain. Because the doctor didn't take into consideration the inclination that the lower molar have in a lingual direction, where the crown is to the lingual and the root apices are to the buccal, more and more going from the first to the second and to the third molar. So if you want to take an X-ray and be perpendicular to the long axis of the first molar, this is the inclination, this is for the second, and this is for the third one. And actually, I always see the opposite, where the inclination is from apical to coronal. Must be coronal to apical, okay? So this is for the first molar, this is for the second, and this is for the third one, not the other way around. And why is made this mistake? Because if you don't consider the inclination of the molar in the mandible, you think that underneath the buccal cusp, what the orifice that you see, you think it is the buccal orifice. And then you start looking for the lingual. But under the buccal cusp, because of the inclination, you have the mesiolingual orifice, not the mesiobuccal. So you have to look for the other one in the opposite direction, here and not here. I see cases like this where the dentist didn't stop on time, and so he made a perforation. Another mistake is here. The inclination is wrong. So it's impossible to make a perforation on the palatal side, but it's very easy to make perforation on the buccal aspect. And this is the typical case that I received. This is the wife of the lawyer, my goodness. And so the colleague was not able to find the canal, and she referred to me, the young lady, with a big, huge perforation that I treat with white MTA, and this is my postoperative film. And this is the CBCT taken somewhere else, not in my office. But you see the wrong inclination and the terrible perforation that I see with the white MTA. The problem is that the white MTA that I used at that time was the ProRoot white MTA by Dentsply Sirona, which was still containing a bismuth. And the bismuth is responsible of discoloration. So it looks like I sealed the defect with amalgam instead of using white MTA. So I had to open the access cavity, remove part of my white MTA, bleach the crown, and from now on, I don't use ProRoot MTA, especially in cervical area repairing perforation in the front teeth, but I use this one here, PD white MTA, made by the same company who makes the map system, because this one here doesn't have bismuth anymore. So it's not causing any discoloration. Also, the setting time is about 10-15 minutes. So very, very important. So as you see, this is during bleaching, and this is after the bleaching, okay? This is another case with a big, huge perforation. It's a long story, but I will make it short. This is the granulation tissue in the pulp chamber coming out from the perforation. This is calcium hydroxide for 1 week on top of the granulation tissue. 1 week later, the granulation tissue has been removed completely without causing any bleeding. So now it's time to position white MTA from produit inter, not causing any discoloration. So this is my white MTA, and obturation of the canal with a vertical compaction, and this is a 3-year recall. This is another interesting case where the colleague told the patient, listen, looking at your postoperative film, I can tell you that I was able to feel a very unusual internal resorption in the palatal root. But the patient was still in pain after the treatment. So she was referred to me by another dentist. And this is my preoperative film. I took an off-angle X-ray to demonstrate that this material was not inside any internal resorption, but was in the trifurcation positioned there through a big perforation of the floor of the pap chamber. And the patient also had the sinus tract. So little by little, with the micro debrider, which is a headstone file connected to the plastic handle, I was lucky enough to remove one after the other every single piece of gutta percha. I took an X-ray to make sure that I remove everything. This is the resorbable collagen inside the lesion to act as a barrier to prevent big extrusion of MTA. I'm condensing gray MTA here. I cover the entire floor. So this is my immediate post-op after sealing with MTA. And this is a recall. Thank God there was no periodontal involvement and the sinus tract disappeared. And this is the last 3-year recall. I think the patient was very lucky because in a case like this, if the periodontal involvement is established, the prognosis becomes very, very poor. Okay, let's see now other mistakes looking for canal, orifice, and calcified canals. And this is the typical case that I received, as I already told you, probably once a week. The colleague was looking for the canal in the wrong direction. He stopped on time and referred the patient to me. I put the patient under the rubber dam, and thanks to the microscope, I was able to find one of the 2 canals of this upper first premolar. So I clean and shape one canal to the working length. And then I started to look for the other one, and was so calcified. And even though I was working under the microscope, it was impossible for me to find the second canal, the palatal. So I said, I removed the rubber dam of the patient, and I put the patient under the CBCT machine. And I took the CBCT, and from this coronal view, I can tell that I was going too much to the palatal, but however, I couldn't see any trace of the lingual on the palatal canal. And going more and more apical, and the apical 1/3, I saw one orifice, one foramen, perfectly in the center of the root, which means that, thank God, the 2 root canals were merging to a common foramen. And so I told the patient, listen, I cannot find the other canal, but you are a sinus tract. You have a sinus tract right now. So come back in 1 week. And if in 1 week the sinus tract is completely healed, that means that I clean and shape the only canal having the foramen and be responsible of the lesion, because the 2 canals are joined together. And this is exactly what happened. So this is the lesion. This is my postoperative film. And this is a 2-year recall. So there was no need to insist and look for the other canal, because the 2 canals were joining together. And the same in this case, in this lower molar. 1 canal, I found it, 1 in the mesial. This is the rendering, big lesion on both sides. And in the mesial, I see 2 canals joining together. And if I cannot find one, I give up, okay? Because the 2 canals are joining together. As you see, there is no trace, but there is only one foramen. Only one foramen exactly in the center of the mesial root. So relax, there is only one canal responsible. And if I found that one, the lesion will heal. So this is my confit, my post-op, and this is a 1 year recall with a nice healing. I found one canal. I couldn't find the other one, but I knew that the other one was joining together. So there's no need to look for it. This is a case that I really love it because it's another case where the colleague was looking for the canal in the wrong direction and he was almost making a perforation. And here I'm working to find the canal in the right direction, more to the mesial and more to the palatal, using ultrasonic tips and magnification. But I like this case for another reason. The central incisor, which was also involved with the big lesion, had an open apex. And so I knew I was going to use MTA as a barrier, like I always do when I treat open apices. And before using MTA, I need to use calcium hydroxide for 1 week to raise the level of pH, because when I have acute inflammation, the pH is pretty low, and so the MTA is not going to set. So don't worry about this video, but take a look of what I did. This is some extrusion of calcium hydroxide. This is white MTA at the apex. This is my post-op. This is after 6 months. But I want to show you the CBCT. Look at the lesion. Look at in the axial view, no more cortical bone. Look at the sagittal view, the lesion and no cortical bone. But the most exciting is the rendering. Look, here, an oral surgeon, he does surgery, scratch the bone, make a disaster. I did a non-surgical endodontic therapy. This is after 1 year. And this is after 2 years, without any surgery, without any bone graft, without anything. Okay? Look at the cortical plate. Back in place. Back in place. Look at the cortical plate. This is without surgery. Is a lesion of endodontic origin. Okay? This is dedicated to oral surgeons and maxillofacial surgeons who, I insist, don't know anything about endo. Look at the beautiful healing. Okay? Same case. Same case. Same case. This is a similar case. Again, looking for the canal in the wrong direction.
Arnaldo, scusa, avevamo pianificato un'ora, stiamo un po' sforando.
Sì, ma avevo avvisato che avrei un po' sforato. Se la gente ha pazienza, se no accorcio e salto.
Sì, conviene un po' accorciare, sì, grazie.
Accorcio. Ok, no problem. Vado l'ultimissimo argomento, che è vabbè, qui si entra in polemica. Voglio solo insistere su questo concetto qua. Perché, excuse me, I was speaking in Italian with you. I'm making my presentation a little bit shorter because there are so many the mistakes that I find in endodontics that I remove some of them, but still my presentation, I realize, is too long. You are busy, you are tired, and so on. But let me insist on this concept because it's a very controversial one, but it's absolutely important. It's the one which makes the difference between being successful and having a failure. The apical patency. Apical patency and the use of the patency file is extremely important. That means that at the end of your cleaning and shaping, you must be able to go with a very small instrument, not a big one, but a small 08 or 10K file, having the apex locator connected through the foramen to make sure that the foramen is open and not blocked by dentin debris. This is the case that I received after the colleague was trying for months to arrive to the end of the root canal therapy, and the tooth was comfortable only when it was left open. what I found that one of the 3 canals were packed with debris, and reestablished patency was the meaning of having success, and the pain disappeared in a few days. So I insist, maintaining the terminus of the canal, avoid blockages, ledges, and perforations. Like this, blockages, ledges, and perforations. Okay? But let me show you. Maintaining apical patency does not increase postoperative pain. Actually, it does the opposite. Let me show you this case and then I quit. Did ever happen to you if you have if you are used to the use of the patency file? Did ever happen to you that the patient comes back to you the day of obturation and she tells you that the tooth was sensitive for the first 1 or 2 hours when she came back home after the cleaning and shaping procedure? And when she comes back for the obturation procedure, she tells you that the tooth was sensitive for the first 2 hours and then perfectly comfortable. When you open the tooth like this, you will find why it was painful for the first 1 hour and then nothing more. And in one canal, you find the accumulation of exudate, which was able to accumulate in the canal because the foramen was open and patent. That's why after 1 hour, after the canal was full of exudate, the pain disappeared. If you leave the foramen blocked with your debris, the exudate has no room where to accumulate, but it will accumulate inside the periodontal ligament between among the bone trabecular, and the patient will be uncomfortable for days and will take antibiotics and so on. In this case, just keeping room, space for the exudate, the pain will have no pain after the treatment. That's why I insist on the importance of a apical patency. So let me finish just showing the cover of the new edition of my textbook, which is also available in English now. And let me spend 2 words to explain the reason of the cover. I don't know if you're familiar with the work of Walter Hess, who 100 years ago made an interesting study on extracted teeth, where he removed all the pulp tissue from the root canal system. And after the system was completely empty, he injected vulcanized rubber inside. And then he made the teeth transparent and showed this bizarre anatomy that was discouraging many endodontists, but not Schilder. Herb Schilder, looking at the Walter Hess anatomy, he said, well, of course, I cannot put instrument in every ramification, isthmus, lateral canal, but I will put my irrigating solution who will do the job for me, digesting everything. And then when I put inside a piece of rubber, which is a gutta-percha point, and I soften with heat, and I compact with the vertical compaction, not lateral, vertical compaction, the material following a law of physics, which is the law of Pascal, will enter by itself in every empty space. And so I will take care of the crazy anatomy. So I said myself, if Schilder was right, I must be able to have in my postoperative film the same anatomy that was shown by Walter Hess 100 years ago. And this is exactly the same anatomy. Look at this. Look at this. Look at this delta apical ramification. Look at this circle. Look at this crazy anatomy. And look at this, the last one here and there. They look exactly the same. Well, you can obtain without any effort on our side, but you can obtain these results only if you use the vertical compaction of one gutta-percha. Can be Thermafit, can be Schilder, can be Buchanan, but please stop using cold techniques, and first of all, stop using cold lateral condensation, okay? Because you will never have this result, which means that you leave part of the root canal system untreated. So this is the end of my presentation. This is my email address. If you want to send me questions, I will be happy to answer to you. This is my website. This is a textbook in about microsurgical endodontics, which is available in Italian, English, and Spanish so far. But before the end of the year, will be available also in Russian and Chinese. And this is the text on endodontics, available right now in Italian and English. So sorry for being late. I apologize, but I had too much material, and I understand you are tired. So this is the end of my presentation. I want to thank Ciro and Grazia. And
yes,
Fabio.
but we have to announce also something. So tonight you made a review of all the major mistakes that people can make in endodontics. But
Exactly.
if you have the right protocols, if you know the right techniques, you can avoid all of them. That's why we decided to make a challenge, and this challenge will start next Monday. The challenge will so we will have 4 days with Arnaldo, and we will see all the single problems, and we will talk about them deeply in details, and then Arnaldo will teach you how to avoid all these mistakes. So you can join the challenge, and here you have the link. You can get all the information. So if you don't have the time to see the challenge at that time, you can watch the replay so you don't miss anything. So there are very important information, and Arnaldo will be available for you directly in your office. You don't have to move from your office. You don't have to take planes. You can stay in the comfort of your office and watch Arnaldo, and he can teach you how to avoid the mistakes. And then Ciro, if you want, you can play the video, please.
Sure, here I am. I want to thank you, Grazie. I want to thank you, Arnaldo. I'm pretty sure everybody enjoyed your presentation and probably would have stayed for many hours listening and watching your presentation. Probably besides the oral surgeon or maxillofacial. And yes, I want to share the video. Give me just 1 second.
Do I see the video also?
Sure,
Part of the presentation.
If you cannot open a correct access cavity, you are not able to negotiate a calcified canal, you don't know how to avoid to make a perforation, you cannot remove a broken instrument, it's not your fault. The only reason is that you don't have the right strategies and the right techniques. That's all. This is the typical case that I receive almost once a week. The colleague was struggling, trying to find the orifice of the canal. As you can see, the pulp chamber is completely calcified, and also the root canal looks completely calcified. But if you have the right strategies and the right instrument, very easily you can arrive to this final result. This is already a 2-year recall evaluation with a perfect healing, and as you see, the root canal treatment has been minimally invasive. We don't enlarge the canal so much, and we are very, very successful. Now, if I was able to obtain this result, everyone who has the same instrument, the same technique, the same knowledge can arrive exactly to the same result. For these reasons, I created a 5-day challenge dedicated to dentists who want to improve their skills. My goal is to help dentists to remove the stress and to use easy techniques to be successful in their daily practice. My name is Arnaldo Castellucci from Florence, Italy, with a great passion for endodontics. I hope to see you online very soon. So click the link below to get access to the challenge that will change your life. Grazie.
Okay, beautiful.
See?
Okay.
So you did a great presentation. A lot of people are saying that they learned a lot, And
Okay.
there were a lot of people from all around the world. So thank you, Arnaldo, for everything.
Thanks to you for organizing such a webinar, and thanks to all the people who were patient enough to listen to me for so long.
Okay.
Thank you both of you. I hope to see you soon, maybe in Napoli.
For sure. I will be in Naples middle of July.
Perfect. Maybe I will call you. So
Okay, for sure. I will give a lecture at the University Federico II, and then I will have a wonderful weekend in Capri Island.
perfect, perfect. Good choice.
Okay.
Okay.
Bye bye to
Thank you.
everybody.
Bye.
Bye.
Bye bye.